In fluid homeostasis, water should be distributed between the intracellular, intravascular, and interstitial spaces and balanced in the correct proportions. Disruption of the normal dynamics of fluid homeostasis with positive net filtration out of the intravascular space into the interstitial space can result in the pathological state of edema. Edema in general would be defined as the accumulation of excess fluids in the interstitial tissue spaces or body cavities. The increase of fluids in the interstitial space commonly occurs from either an increase in capillary hydrostatic pressure or reduced plasma albumin that reduces plasma oncotic pressure and water reabsorption into the capillary, consequently causing net filtration of water out of the capillaries. Other mechanisms that may cause the collection of fluids in the interstitial spaces includes lymphatic obstructions that cause reduced drainage of excess fluids and proteins from the interstitial space, and increased capillary permeability, usually in the setting of inflammation, causing escape of fluids, proteins, and inflammatory cells into the interstitium. A clear distinction, however, has to be made between the first two mechanisms caused by increased hydrostatic pressure or reduced oncotic pressure that causes the collection of predominantly water in the interstitial space, referred to as a transudate, as opposed to lymphatic obstruction and inflammation that causes accumulation of protein-rich fluids in the interstitium, which is referred to as an exudate. Increase in capillary hydrostatic pressure causing generalized edema most commonly occurs in the setting of cardiac failure, particularly congestive cardiac failure or CCF in short. In CCF, there is reduced ventricular ejection and venous return due to poor myocardial function. As a consequence, blood begins to pool in the cardiac chambers and veins with back pressure on the veins, increased capillary hydrostatic pressure, and edema. Additional compensatory mechanisms triggered by the renin-angiotensin-aldosterone system and the sympathetic pathways in cardiac failure may cause intravascular volume expansion and further aggravate the edema. Local obstruction of veins, usually leading to localized edema, may occur due to obstruction to capillary venous return, causing increased back pressure on the capillaries, causing edema. A third mechanism that may increase capillary hydrostatic pressure is the loss of arteriolar precapillary sphincter control, leading to vasodilation, increased capillary blood volume within the capillaries, and therefore causing an increase in the capillary hydrostatic pressure. This is, however, an uncommon mechanism causing edema. Cardiac failure causing reduced ventricular ejection of blood, increased pooling in the veins, and intravascular volume expansion, as alluded to earlier, is most commonly seen with congestive cardiac failure, but it may also occur as a consequence of other cardiac pathologies such as constrictive pericarditis and cardiomyopathies. Obstruction of venous return causing increased back pressure on the capillaries is seen in conditions such as pregnancy, which is often associated with bilateral lower limb edema, and also in venous thrombosis, which causes localized edema to the area drained by the obstructed vein. External compression of the vein by malignancies or adhesions may also cause localized edema. The loss of arteriolar precapillary sphincter control is seen in conditions such as heat stroke, allergic angioedema, or may be occasionally drug-induced. Edema can also occur to hypoalbuminemia that leads to reduced intravascular colloid osmotic pressure and escape of fluids out of the circulation. Common conditions associated with hypoalbuminemia include urinary protein loss, such as seen in nephrotic syndrome, and failure of protein synthesis, as in liver failure and liver cirrhosis. Less common conditions include protein losing enteropathies associated with certain malabsorption syndromes and protein malnutrition, as in kwashiorkor.